I think we're there.
I've got 5 right now.
Yep. So that'll do it, right?
6.
And we need 6. Okay.
No, I mean, I have 6.
Oh, perfect.
Not
Okay.
everybody's on camera, so it's hard. I'm trying to read the names. Yeah, I think we're okay.
Okay. Very good. Well, it is 5 o'clock, October the 9th, 2025. I will call this Durham County Board of Health meeting to order. I hope everyone is doing well and ready to have a very efficient meeting today. Hopefully, we've all had an opportunity to review the agenda that was sent out and the adjusted agenda. Thank you, Donna, for that. And if so, I will entertain a motion to accept the agenda as modified and printed.
So moved.
Second.
It's been moved and properly seconded. If there's no unreadiness, Donna, we are ready for the vote.
Okay, Dr. McDougall,
Yes.
Dr. Ray,
Yes.
Mr. Brown, Dr. Glover, Mr. Gregorio,
Yes.
Dr. Jackson,
Yes.
Dr. Miller,
Yes.
Dr. Orto,
Yes.
Dr. Silberman, Commissioner Valentine, and Dr. Verbiest.
Yes.
Thank you.
Awesome. We also have had the opportunity, hopefully, to review the notes not only, or the minutes, not only from the August meeting, but also the June meeting. There was a correction for the June meeting that Donna made for us. So if you've had an opportunity to review those, and if you have any additions or amendments, we will accept those, or we will entertain those now. Otherwise, we'll entertain a motion to accept both the June 12th, 2025 and August 14th, 2025 minutes.
Motion to accept both.
Second.
All right. It's been moved and properly seconded. If there's no unreadiness, we are ready for the vote on the minutes.
Okay, Dr. McDougall,
Yes.
Dr. Ray,
Yes.
Mr. Brown, Dr. Glover, Mr. Gregorio,
Yes.
Dr. Jackson,
Yes.
Dr. Miller,
Yes.
Dr. Orto,
Yes.
Dr. Silberman, Commissioner Valentine, and Dr. Verbiest.
Yes.
Very good. Donna, do we have any public comments for this evening?
No, we don't.
Awesome. All right. Well, we'll turn this meeting over to the capable hands of our director, Dr. Jenkins, for staff and program recognitions.
Thank you so much, Mr. Chair, and good evening to this great board. Just want to say thank you for all that you do and just let you know how much we appreciate your work and your service to the community. It's always good to see you all. I will say, for the most part, I have an abundance of recognition, and I'll try to be as brief as I can. I definitely want to give Dr. Jackson, LaRon Jackson, a shout out. Most recently, we saw her in action at the Durham Pride Festival here, I want to say a couple of weeks ago. And that was my first time actually meeting her in person. But it was great to see her with her colleagues from UNC Medicine. And I just want to really give her a shout out, thank her for her service to the community. I'd
Thank
also
you.
like to really emphasize a lot of our partnerships. We have partners that really help us to do this great work in public health, which is not easy. And those partners most recently were recognized. First and foremost, Dr. Bobby Banks with Pillar Consulting. She sponsors a program that deals with youth to help educate them about public health and life matters. And recently, through the tremendous nomination process spearheaded by Lindsay Bickers-Bach from our Health Education Community Transformation Division, she received the Association of North Carolina's Boards of Health Partnership Award. And there was a ceremony last month that I attended, And it was just delightful to have her to be able to be recognized. So for the most part, I just want to say thank you to Lindsay for putting together a really jammed up nomination. And we are so appreciative of our partnership. The second award was, I believe, was spearheaded by Marissa Mortarboy, our Population Health Division Director for the North Carolina Public Health Association. And that partner award went to El Centro Hispano. And they were able to join us in Wilmington at our Fall Education Conference and receive that partnership award. So I want to say thank you to Marissa and team for that nomination. And it's always great to recognize our partners. Central Hispano is a longtime partner of Durham Public Health, and under the leadership of Pilar Roca Goldberg, my great friend. So we want to make sure we recognize that. Last but not least, you may have heard we have been doing some spraying for mosquitoes, and the communication could have been a little bit better. I've said that publicly and I own it. However, we had some scheduling conflicts and due to weather, so we had to push it up. To the Durham community, I do extend a heartfelt apology. Just know that we learn from our mistakes, and that second round of spraying is coming next week, and we have promptly put out a nice press release and a lot of information on social. But this is recognition time, and I'd like to recognize Chris Salter, who is our Environmental Health Director, who behind the scenes have been doing a lot of work with the bidding process, the procurement process, and just putting a lot of care and effort into ensuring that the chemicals that we use and the process is as such to not be as harmful or harmful at all to the community, but to get the job done, which is to kill the mosquitoes that carry the West Nile virus. And I'd also like to recognize Dr. Alicia Smith, who is our Communications and Public Relations Officer. I honestly don't know how she does it all. She is a one-woman army, and she does a very good job of getting a lot of information out to the community. But then conversely, she also feels a lot of the complaints and a lot of the disgruntled individuals who are not afraid in Durham to express how they feel. So where credit is due, I certainly want to laud and applaud those individuals for a job well done. That is it, Mr. Chair. Back to you, sir.
Very good. Thank you. And I will echo the sentiments expressed by our director, Dr. Jenkins, and congratulating especially our recent award winners. I won't dare try to name them all or all of the folks that, in addition to the award winners, all those hardworking staff members of the Department of Health. So congratulations to you. Thank you for your continued hard work, and we'll continue on. The next thing on the agenda is our administrative reports and presentations. We have a report from Paul Weaver on HIV Bridge counseling. So we'll give way to Paul at this time.
All right. Thank you all for having me. Before I begin, I'd like to thank my counterpart, Aaliyah Davis, the disease intervention specialist that I work with directly, the STI clinic, and the leadership at the Department of Public Health. Thank you all for your time, and thank you all for having me today. I really appreciate it. So let's just get started. All right, so before I start going right into bridge counseling, I'd like to paint a picture for you all. All right, this first slide is an aerial view of the Huajing Grand Canyon. This is a rugged, ravine-ridden terrain in China's Gansu province. Let's say you all are individual patients and you and I together need to cross this canyon by foot. This would be extremely dangerous and not advisable, being that the canyon is renowned for its treacherous, rugged terrain and a massive gorge over 2,000 feet deep. So to make things easier, let's just build a bridge. Now, this next slide, this is the development of the Huajing Grand Canyon Bridge. It is approximately a mile long and 2,051 feet from its deck to the stream below, earning it the title of the highest bridge in the world. Seeing the development of such a bridge reminds us of what bridges truly do. They make the impossible crossing possible. Bridges span a gap. They connect 2 points that will otherwise be separated by a risky or uncertain gap. In HIV care, the gap is the vulnerable period after someone receives an HIV diagnosis, but before they're engaged in treatment and support. Us as bridge counselors help people safely cross this gap so they don't fall into fear, stigma, or disengagement. This is the finished Huajing Grand Canyon Bridge. Its design reflects strength, stability, and purpose. Like all bridges, it offers a clear path forward, providing stability and direction. Us as bridge counselors provide structure and direction at a time when clients feel lost or overwhelmed. We clarify next steps and guide clients towards safety and care. Providing structure and direction helps clients find their footing after diagnosis, but bridges are not destinations. They are meant to be crossed. You don't live on a bridge, it's a transitional space to get somewhere else. Similarly, HIV bridge counseling is not meant to be long-term therapy. It's short-term, focused support until the client is connected to ongoing medical, psychological, and community resources. Once the bridge has served its purpose, the traveler reaches solid ground and connection. Crossing that bridge brings people closer to the communities that might otherwise remain cut off from one another. HIV bridge counselors connect newly diagnosed individuals to the broader community of care, such as providers, support groups, prevention services, and treatment networks. Reconnecting people to care and community is only the beginning, though. The next step is helping them build the trust and confidence to engage fully in treatment and life. Connection lays the foundation for trust, and trust is what allows true healing to begin. In counseling, trust is key. Bridge counselors offer compassionate, non-judgmental support so clients feel secure enough to step forward and begin treatment. This next slide is the North Carolina HIV Continuum of Care. That's from 2023. A lot of you all probably have already seen this before, so I'm going to try to move quickly with this. But in regards to people living with HIV in North Carolina, 91% are diagnosed and reported. 77% have at least one care visit. 72% are retained in care, and 67% are virally suppressed. Now, when I look at these figures, I think about the figures that are missing. I think about the 9% who are undiagnosed and not reported, the 23% who have never had a care visit whatsoever, the 28% who are not retained in care, and the 33% who are not virally suppressed. And this is just the current state of HIV. In North Carolina, we have 41,290 people living with HIV and AIDS in North Carolina. Of those, 3,800 people are undiagnosed with HIV in North Carolina. And in Durham County, we have approximately 2,000 people living with HIV. And in the state, there are 10 state bridge counselors, and they're in different regions. The next slide shows the map of where they're located. In Durham County, we have 2 bridge counselors. Wake County has 3, and Mecklenburg County has 5. Now, Mecklenburg County, when I did this, was trying to add more bridge counselors, so they may have more than 5 now. And this is just a state map. We're in Region 4, the Raleigh-Durham region. Our state bridge counselor is Alma Rodriguez and Kenya Gunn. And in Durham County, Aaliyah Davis and myself are the bridge counselors. Aaliyah Davis, she's a 2018 NCCU graduate with a degree in public health education. I am a 2008 and 2017 NCCU graduate with an undergraduate degree in public health education and a master of public administration. And we both started in March of 2024. So we literally started on the same day last year. And what do? That kind of leads back to the bridges that we discussed earlier, right? We assist in linking newly diagnosed clients into care. We locate, re-engage, and link out of care or lost to care clients. We identify and address client barriers to care. we verify care status, and we make appropriate client referrals. Now, this is a question we get often. A client is considered in care if, one, there's documentation of virologic suppression within the last 6 months, or they have 2 or more of the following indicators at least 3 months apart within the last 12-month period. 1, an HIV clinical visit, and that has to be confirmed by the provider. 2, CD4 counts. 3, HIV viral load, and 4, prescription refill. Now, there are 4 things listed, but to be honest, it's really 3 things, because the CD4 count and the HIV viral load, usually those happen simultaneously. So oftentimes we're looking for a clinical visit, we're looking for labs, and we're looking for medication, in short. And this last bullet states clients who meet the in-care criteria, but do not have a documented suppressed viral load in the past 6 months, or are consistently non-suppressed with a viral load greater than 1,500 copies per milliliter, despite having other in-care markers, are eligible for bridge counseling intervention if assigned. So that's saying a lot to say that we have an individual who is doing everything they're supposed to do except taking their medication regularly. So in that case, we may have a bridge counselor intervene. And here's a list of the barriers to care. I won't necessarily read each barrier to care, but I will say that the top one for most patients that we see is transportation. Now, every client, every patient has different issues, but for the most part, transportation is just a major barrier for a lot of individuals trying to get into care and stay in the care. When Lee and I first started, March of 2024, there were 850,000 bridge counseling cases open in North Carolina. Once again, 850,000. Since March of 2024, Ali and I have closed 174 cases, and 29 of those cases were successfully linked back to care by Ali and I. And this slide right here is just a figure of our collaboration with Duke Clinic 1K. We have a really good relationship with the staff at Duke Clinic 1K. And I think we have a good relationship with all the HIV providers in the area, whether that's UNCID, the Early Intervention Clinic at Lincoln Community Health Center, or Duke Clinic 1K. The one thing about this slide, as you can see, is as we work more and more together, we were able to get more and more visits completed. With this in August 25, I believe there were 59 patients. Of that, there were about 25 who had their visit completed. And there were another like 26 or 27 who were missing. We had a few that had moved, and then about 5 or 6 who had visits pending. And to this date, I believe most of those visits were completed. So why are patients not linked? Once again, a long list. Each patient is different. Their reasons for not being linked or not getting into care are different. I would say of the list, the top one were probably just unable to locate or lost to follow up out of those 174 cases that we've closed. And I like to say of those 174 cases that we closed, some of these cases were from like 1990, 1991, 1992. Where an individual tested positive and had never been into care. So we were trying to find people 20, 30 years ago. And this next slide is just what patients have said. I won't read, all these statements from patients, but I will say all these patients, these 4, were out of care. They didn't want to be in care when we first engaged bridge counseling. And they all, to this date, are still in care now. I think this slide just highlights the impact and effect that bridge counselors can make on individuals, and kind of getting their barriers out the way so they can focus solely on being in HIV care. So this is a picture of the Ruyi Canyon Glass Footbridge in China. This bridge is 330 feet long and 460 feet above ground. And I like this bridge. I like this picture because this really kind of shows or depicts some of the things that our patients go through to get from one side to the other side. Sometimes we get them and they're on the high. You know, they are doing everything they need to do. They're in care. They may be missing one thing, but they're on the high. We have some patients who are low. They're really low. You know, they have a lot of different issues, a lot of different barriers, and we want to keep working with them to bring them back up. Some patients, we start off good and they veer to the right, they veer to the left. Regardless, we all try to get them to the end, to the other side of that bridge. And we try to prevent the patients from falling down into this great canyon that you see, right? And at the bottom of that canyon, I like to say is fear, stigma, disengagement. So we never want patients to fall from the bridge into the canyon. But if they do, we'll go down and get them. And we'll cut down the trees to eliminate the barriers. We'll climb back and we'll get back on that bridge and try to cross it again. So with that being said, this is the end of my presentation. Do we have any questions?
I did have a question, Mr. Weaver.
Yes.
First, let me thank you for your great presentation, a lot of valuable information there. I think I know the answer to my question before I ask it, but just in case someone else is wondering the same thing, I think it was in slide 5, you had a very specific number, I think 3,800 undiagnosed
Yes.
cases. Is that truly undiagnosed currently, or is it undiagnosed until they were coincidentally diagnosed? How do we know they're undiagnosed if they're
Well,
undiagnosed?
I will say this from the state, North Carolina State Department of Public Health. They had this number listed in their PowerPoint from 2024, I believe. That's a great question. I'd have to research that with the state and kind of get back to you and get you an accurate answer. But I can't answer that definitely right now.
Okay. No
Paul,
problem.
do you mind if I just jump in?
Sure.
Real quick? Yeah, Chair McDougall, it's a formula. The CDC has a formula where they basically take, these are the known diagnoses, this is the population, and we know that a certain percentage of people are undiagnosed. So it's a formula. It's a best guess estimate.
Got you. Okay. Thank you, Dr. Jenks.
Thank you, Dr.
Mr.
Jenks.
Weaver.
Appreciate that.
All right. I see Mr. Gregorio has his hand up. You have the floor, sir.
Thank you. And really just a positive comment to you, Mr. Weaver and Miss Davis. My brother is an Eagle, also went through the public health education department, amazing program, gives out amazing leaders like you all. So thank you so much for what you all do.
All right. Thank you. Once again, thank you for having me. Appreciate it.
Awesome. I see Dr. LaRon Jackson has her hand up. You have the floor.
Thank you. Thank you so much, Paul, for that excellent presentation. I did have a question regarding one of the major factors that you mentioned in being a barrier to care, which is transportation.
Yes.
Have there been any thoughts around programming, grants, funding, anything to really kind of help link people with the transportation resources that they need?
Yes. So UNCID has transportation to and from appointments. So patients who see providers there have access to transportation as long as they don't live 30 miles away. Duke does not have transportations to appointments. They have services or assistance going back home, but not necessarily to appointments. And the early intervention clinic has no such services whatsoever. Right now, leadership, you guys are here, you guys could chime in, but right now, as I know it, there isn't anything right now that we're doing.
Okay. And thank you. And my second question was regarding partnership with any harm reduction programs as far as substance use to try to really kind of address spread in those populations that are also have comorbid substance use disorder?
Yeah, I mean, yes, we definitely make referrals for patients who have substance abuse issues. There was one patient that I worked with, and he ended up, going to the Freedom House for substance abuse treatment. So yes, we do make referrals for those type of things and try to make sure that those clients, just like they go to their HIV provider, go to their substance abuse treatment provider, whatever. So I think I say that all that to say, it's wraparound services, and in order to get people in care for HIV, you have to kind of deal with the other things as well that affect them, and you got to take care of the whole person, not just the HIV part of the person.
Absolutely. Thank you for your work.
Yes, ma'am. Thank you.
All right, I don't see any other hands up. So once again, thank you for that great report, Mr. Weaver and team. And we will move on to the next presentation, which will come from Bria Miller. I see her there at the bottom of the screen, ready to give her presentation on the state of the Durham County of Durham County Health Report for 2024. Ms. Miller, you have the floor.
Thank you. Good evening, everyone. It is always a pleasure and an honor to be before you and to speak. Again, my name is Bria Miller. I'm the Partnership for Healthy Durham coordinator, and the Partnership for Healthy Durham is our community-wide health coalition that responds to Durham's top health issues, and those health issues are determined through our community health assessment process. I'm a part of the Population Health Division that is led by Marissa Mortiboy. So I will go ahead and get into it and share some of the highlights from our 2024 State of the County Health Report. Okay, so this State of the County Health Report provides an update on the priority health issues that are identified through our community health assessment process. I will probably call it the SOTCH just because that's a little quicker to say, but it does explore emerging issues and it highlights new initiatives. We submit this every year that a community health assessment is not submitted. So this most recent one is based on the 2023 community health assessment. Here's a look at our current top health priorities: affordable housing, access to healthcare and health insurance, community safety and well-being, mental health and physical activity, nutrition, and food access. And so these top health issues were identified through a bit of a different process this time, but we did look at our community health assessment data, secondary data, and as well as listening sessions that were held in English and in Spanish. Now looking at some of our emerging issues and new initiatives, and I will say there's a whole lot more going on than what I will cover in this presentation, but we have limited time. So thankfully I get to highlight a few of the things that are happening though. So Durham residents did vote to improve transportation infrastructure through bond referendums. So this happened in November of 2024. This to me shows that Durham residents are committed to making improvements to our streets, sidewalks, and parks. There was an overwhelming approval of votes. So 72% of votes were approved for the streets and sidewalk bond and 75% of votes for the other. And this would make up a total of $200 million that we are using towards improving our city's transportation network, enhancing various infrastructure projects, and developing public spaces. We also saw that the total number of unsheltered people in Durham has doubled since 2020. So the total number of unsheltered people in Durham, so this means people sleeping in cars, on the streets, or in the woods, is up by 123% since 2020. The unsheltered count increased by another 9% from 2023 to 2024, with 158 unsheltered people during the point in time count. The number of homeless children increased by 58% and families increased by 31%. Homelessness disproportionately impacts Black or African Americans in Durham due to systemic issues that cause poverty, barriers to resources, and limited opportunities to obtain generational wealth. Also, as I'm sure you all are aware, we are also doing some work in the area of to reduce drug overdoses and substance misuse. So, of course, Durham County received $11.6 million in opioid resettlement funds over an 18-year period. Durham County hosted nearly 70 community members for a discussion on the opioid settlement fund in June of 2024. And the top 3 strategies identified were evidence-based addiction treatment, evidence-based recovery support services, and recovery support housing. Now looking at demographics and life expectancy, Durham's population continues to grow. The total population is 329,405, which is an increase of 3.7% from 2020 to 2023. Its racial and ethnic makeup continues being diverse. People ages 25 to 34 make up the largest age group of residents, followed by those ages 5 to 17, and then those 65 and older. Durham residents' life expectancy is higher than North Carolina's. The average life expectancy of a Durham County resident is 79.2, while it is 76.2 for North Carolina. Now looking at leading causes of death and infant mortality. Cancer remains the leading cause of death among Durham residents. Following cancer is diseases of the heart, accidents, and cerebrovascular diseases such as stroke and brain aneurysm, and then Alzheimer's disease. Infant mortality is the death of a baby before they reach 1 year of life. The infant mortality rate remained steady from 2018 to 2022 compared to 2017 to 2021 here in Durham County. There are still significantly higher mortality rates in Black or African American babies than other groups. There are many groups doing work to help to combat this issue. Family Matters Durham is a program here at Durham County Department of Public Health that promotes and supports breastfeeding for families. Also, you have Family Connects Durham, which is a community-wide nurse home visiting program for all parents of newborns, regardless of income or socioeconomic status. Now I'm going to get into some of the updates or the changes in data as it relates to the top health issues here in Durham. So you can see here, this one is on affordable housing. So this is, again, the top health issue here in Durham. A large portion of Durham residents are housing cost burden, with about 18% of renters consider housing cost burden, while about 45% of homeowners are considered housing cost burden. Householders over the age of 65 are disproportionately impacted by severe housing cost burdens at 49% compared to 29% of householders ages 25 to 34. So some of the initiatives that we've had in 2024, the Partnerships Health and Housing Committee hosted a series with many different sectors throughout the community, because looking at the intersections between health and housing is fairly new, but we are getting to a point now where we are gaining an understanding and we're able to develop a comprehensive list of organizations and natural community resources that will aid in the health of our community and its housing. And now they are looking to do a neat project that would involve some mapping. Also, the City of Durham Neighborhood Improvement Services completed 7,380 housing inspections and performed 10 neighborhood preservation remediations. Now looking at access to healthcare and health insurance. Access to healthcare and health insurance was identified as the second highest health priority, again, in our community health assessment process. In 2022, 10.59% of the population under the age of 65 are uninsured in Durham County, which is a decrease from 14% in 2019. About 80% of Durham residents have private insurance, while about 75% of North Carolinians have private insurance. As a result of Medicaid expansion, nearly 16,000 Durham County residents had enrolled in Medicaid since November of 2023, which is when it rolled out. Some progress that was made. So the Access to Care Committee has developed a new brochure for uninsured and underinsured Durham County residents, and we very intentionally used more plain and inclusive language. Also, the Lincoln Community Health Center serves about 10% of Durham's population, with about 50% of their patients being uninsured. Community safety and well-being was identified as the third top health priority in this community health assessment process. This one is a new health priority, which replaces poverty. While violent crime is an aspect of community safety and well-being, it also intersects with other health issues, such as traffic and pedestrian safety, and creating a community designed for mental well-being and connection. When compared to similar counties in North Carolina, Durham's crime index is the second highest, following Forsyth County. Other crimes listed: robbery, murder, and burglary are the most prevalent forms of crime in Durham. Social vulnerability refers to the factors that adversely impact communities that encounter threats and other community level stressors, such as poverty and lack of transportation. Durham's social vulnerability index score is 0.69, which is higher than the average in North Carolina and across the United States. So look at some of the work that's being done in our community. So Durham County introduced a guaranteed income program called Decode Thrives, and this provides cash assistance to low-income families in Durham. The program will provide payments to 125 individuals with a child under the age of 18. Mental health was again identified as the fourth top health issue in our 2023 CHA process. The rate of the mental health provider per 100,000 people in Durham is more than double the rate of North Carolina and nationally. The graph on the screen shows death by suicide or drug or alcohol poisoning. Sadly, 703 Durham County residents died by deaths of despair in between 2018 and 2022. There's a decline from 11.9 per 100,000 in 2021 to 7.9 in 2022. While deaths of despair impact all communities, American Indian or Alaskan Native and white individuals are most impacted in Durham. The Partnership Mental Health Committee collaborated with partners for 99 Durham County residents to receive community resiliency model training in 24. Also hosted a series of mental health trainings, which include applied suicide intervention skills training, mental health first aid, and several more. There are also brochures available for low cost and no cost mental health supports. As you all may be aware of, we also have the HEART team in Durham, and they provided 8,107 community team responses, about 1,500 crisis call diversions, and over 2,500 co-responses with law enforcement. Physical activity, nutrition, and food access has been the fifth top health priority in Durham for over a decade. Most health indicators in Durham County related to this priority have improved and are better compared to North Carolina and the United States. Access to exercise opportunities in Durham County has increased from 86% in 2022 to 88% in 2023. As you can see on the screen, the food insecurity rate significantly decreased from 2017 through 2021, but then it increased in 2021, from 2021 to 2022. The food index score, which is a measure combining access to healthy foods and food insecurity, has improved from 7.7 out of 10 in 2019 to 8 out of 10 in 2021. Excuse me. This shows that more residents have access to healthy foods and less are insecure. Obesity rates have decreased from 34% in 2022 to 30% in 2023, and type 2 diabetes rates are down from 12.9% in 2019 to 11% in 2021. Our physical activity, nutrition, and food access committee has been very busy. They've done a lot of great work, and they continue to do things to improve the physical activity levels of all residents. But they have specifically been doing things for youth by installing playground stencils in schools, parks, and areas where families with small children go. We also have that here at the health department. We also collaborate with food distribution sites to identify policy systems and environmental changes to help families access and utilize healthy foods and to reduce food waste. You all may have seen the Open Streets event this past Sunday that happened in downtown Durham. That was part of the efforts from this PANFA committee. And we've been able to do quite a bit since we received funding from the Duke Endowment Grant. Not only does it allow us to have a dedicated staff person to this work, but we are also able to put money towards great initiatives that we want to do or our partners are also doing. Be on the lookout for some great pictures from that event. All right, and on the screen, you just see some pictures. I had lots of graphs and numbers, but I did want to show pictures of what it looks like when people are coming together in our community and the work is actually happening. Folks are still continuing to stay connected, and we're really focusing on what assets we have in our great community, but also recognizing where our gaps are and what we can do to build better solutions together. The State of the County Health Report is available at healthydurham.org. It's in English and Spanish, and we also have a version for people with visual impairments. Does anyone have questions?
Rhea, thank you very much. Very wonderful presentation. I just had a quick question or more of a clarification for something I thought I heard, but I wanted to understand more. On the one slide, you mentioned a significant decrease in both obesity rates and type 2 diabetes rates over the past several years. Do you know what factors are? It seems like that's a big success. What particular factors are contributing there?
Sure. So of course, many things play into that. But I think a lot of it is that we have some really good programs here in Durham that help to combat food insecurity. Things like our Double Bucks programs, which allows families to go to even like farmers markets and get double the amount. You all are probably familiar with that program. But also the fact that we do have many opportunities for physical activity, and we try to make it fun and inclusive for folks. And we do try to talk to residents too. People here like to be connected. So whenever we have opportunities to show people, hey, we have this here, this is accessible, you can do this and incorporate it into your daily lives, that seems to be helpful as well.
Fantastic. Thank you.
All right. I see Anthony Gregorio's hand up, so we'll recognize you, sir.
Thank you. Ms. Miller, wonderful presentation and great work. A two-parter of a question regarding the unsheltered. I saw that in the report that Durham had grown in terms of population only 3.7% from 2020 to 2023 in 3 years, and yet you're telling us that we have doubled in unsheltered or homeless folks in 4 years. It's quite a large increase. I'm curious, one, how do you gather information of someone who's unsheltered? What is the methodology for gathering that information, and two, do we know why there is such a sharp increase?
For that question. So a lot of this information is gathered from our point in time checks. So those are done, I believe, in December or January of each year. And so that's usually how we are able to go out and see like who is actually like on the streets and are like meet this definition of being unhoused. And then you asked about like what else is causing us to have such a high percentage of people or the high number of people who are unhoused. You also saw another slide that housing costs are very high in our community. So I'd say those are a couple of contributing factors. However, I do not at all consider myself an expert in houselessness or homelessness. So I'm sure other people could provide much better context.
Thank you.
Thank you for that question. Dr. Verbiest, I see your hand.
Yes, I just want to say that that was an excellent report, and I am on the Partnership for Healthy Durham email thread. So you show up in my inbox, and I always read your emails, and I just want to emphasize, as someone that gets to see a little of the behind the scenes work, just how complete and comprehensive this is, and how hard you really try to listen to our community and everyone in our community. And I just want to applaud you. And it was really interesting learning about our community. And I guess my question is, how are you sharing back the data with the community?
Thanks for that question. I'm having conversations about that all the time. And thank you also for the compliments. Really appreciate that. So one, of course, we have these reports that are available. But two, whenever we do things, especially like listening sessions, and even whenever we did surveys, we ask people if we can share the information back out with them. So sometimes it is shared via email, but sometimes, especially like at listening sessions, we will host them with groups that convene regularly. And we ask, one, how would you like to receive this information back? A lot of folks like infographics. So we do develop things that are more digestible for folks so they can go and access that information. We do also provide pieces of it on our social media, and you may see some things in the newsletters as well. Yeah, those are the primary ways that we share back the info.
Awesome, thank you. I don't see any other hands. Do we have any other questions or comments? Well, thank you again, Bria, for such a great report, great information. We'll continue on. Let's see. We have our vacancy report next on the agenda. So we'll let our Dr. Jenkins to report on that.
Yes, sir. Again, we continue to see precipitous drop in our vacancy report. Members of this board can remember during COVID times, shortly thereafter, it got as high as 16, sometimes 18%. And that was due to the great migration. Individuals were reassessing their choice of public health, public service, but those times have dissipated. So we ended the month of August at 11.2%, and we continue to work hard, and the month end for September is 10.5%. To put things into perspective, the county at any point in time can range anywhere from 16, as high as 16% vacancy rate on down to about 10%. So when you take that into consideration, public health is doing extremely well as far as filling positions and working with county HR to ensure that we keep that pipeline going strong. So we continue to work hard to make sure that that continues to drop. That's all I have with the vacancy report.
Thank you. Next, we have our NOV report. We'll give way to Chris to present that.
Yes, sir. This report, as usual, is pretty straightforward. Nothing extraordinary to report this meeting, but I will mention that last meeting, we brought up the fact that we were going to probably seek conjunctive relief for the property, non-compliance for the property at 3913 Cheek Road. Just a couple of weeks ago, the owner of the property became more responsive, and we have confirmed that he has applied for sewer extension with the city. So it's moving in the right direction, and we have backed off of court action. So that's a positive. I'd just like to point that out. It's always good if we can avoid court and we're gaining compliance. However, it may take months to as much as a year to get him connected because the city is so far behind. There's still so much construction happening that they've got a lot going on, and it will take some time.
And if I could just clarify, our action is still pending in court, but we're just holding to see if he does what he needs to do.
Very good.
And also, Mr. Chair, if I may,
Sure.
members of the board, just want to really commend Attorney Malott. in working with our environmental health division. She most recently, maybe about a week and a half ago, came to one of our staff development days. And even prior to that, I believe, Chris, correct me if I'm wrong, but she attended a session with our environmental health division and really gave them the real particulars about how she interfaces with environmental health and how she interacts with the courts to get things done. And that was very instrumental. I saw eyes wide open at the staff development day when they really realized how much goes into these environmental health actions, particularly with these notices of violation. So I just want to really publicly thank Attorney Malott for doing that, taking time out of her busy schedule to come to present to the entire staff to really help emphasize how it's all connected. So again, we thank you.
Thank you. It's truly an honor to serve our health department.
Thank you. Any other questions or any other comments regarding our NOV report? All right, we'll move on to our health director's report. Lot of good stuff there.
This is always a tough one because there's so much good going on, but I will just present three things real briefly. You did hear from Bria as far as the Partnership for Healthy Durham and how they work to really get physical activity and a lot of people moving. Was able to really attend with my daughter the movable open streets last Sunday. That was fantastic. Had me out there dancing, and I'd do anything for my little princess. But anyway, it's just a small example of how we work with the community to hear about those things that they need. So again, inside the health director's report is also our health education division, community transformation division, really talking about how they're working with Durham Parks and Recs to really get a lot of colorful stencils and playground equipment to really get our kids moving. We all know, and I have a 14-year-old and he loves PlayStation and Xbox and all that other stuff. But we're trying to really get them back to really going outside and to enjoying the playgrounds and everything. So that's been highlighted. Second thing, of course, is just want to really give credit to Deputy Director Liz Stevens. She worked really hard with our Black Maternal Health Week that culminated in a symposium that was sponsored by Wake County government. But details about our Family Matters Durham and Family Connects, kind of some of the things that were talked about by Bria, is also inside the health director's report. But just really just give Liz a lot of kudos. She worked on that steering committee, and we kind of rotated. So one year it's in Guilford County, last year was in Durham, this year is in Wake County, and I think there might be plans to send it to Mecklenburg County as well. But this is an issue that is nationwide, it's definitely statewide, and coalitions such as this is really helpful in helping us to curb this epidemic when it comes to infant mortality. There's no reason a civilized society such as ours should have babies and moms dying during childbirth and everything. So, and Bria's statistics also show that, disproportionately affects the Black community. So we want to make sure that we take care of that as well. But again, thank you to Liz for that. And equally, I also would like to, third and final, like to thank Deputy Director Kristen Patterson for her work alongside Jason Smith, who is our opioid settlement manager within the package. It's a lot of information about all of the efforts that have gone into establishing our opioid advisory committee. That is a countywide committee that has been established through a lot of hard work, a lot of interfacing with the state. Jason came a short while ago to do a presentation on the work that they do, but he was kind of on the cusp of getting that advisory committee established. So we have accomplished that. And they're working also with our health education division, particularly with our harm reduction efforts. Proud to say that we are making a difference. A lot of naloxone is being flooded in the streets. Is at the point where we're really having to scour our budgets to really get a lot more. That's how much we're able to really disseminate. We do have 2 additional vending machines that are coming, and Morgan Culver and Brad Kaysen and Dennis Hamlet and Jason and team, they're doing a fantastic job in tow with our community paramedics. So it's all beginning to come together, but we still acknowledge that there's a lot of work to do. But Mr. Chair, that's all I have for the report. It's a lot of good work going on.
A lot of good work, absolutely. I did have a couple of questions. I was reading through the entire report, looked at the dental screenings, and noticed that there was a decline in the number of screenings that we had this year. Is there a rationale for why there are fewer, almost 2,000 fewer this year than?
We acknowledge that there has been somewhat of a decline, and that's attributed to we've had some difficulties with our dental van. We are in the process of, well, our dental van driver retired. There were some mechanical issues with the dental van. All of these things have been resolved. We are at the point where we're about to hire a new dental van driver, so we're delighted about that. Every so often, we still face significant challenges with outside vendors who are really for-profit, impeding on our territory, so to speak, when it comes to trying to provide services for the students for Durham Public Schools. So every so often, we have to refresh and remind the superintendent and staff that we do it for free. This is a partnership that we have. But Liz Stevens has her hands up. She can do a much better job of explaining under her purview. Liz?
Thank you so much, Director Jenkins. No, absolutely. I agree with everything that you just shared. And I would invite Jim Harris, our dental director, to chime in as well. I do know from discussions with him that another factor that has contributed to fewer screenings in the schools relates to legislation that was passed prior to this school year, the Parents' Bill of Rights legislation that some of you may remember, which changed the consenting process for screenings in schools, many screenings to include vision, dental, and the like, previously were an opt-out process. And this past school year, that legislation turned it into an opt-in process, which we knew we suspected would reduce our screenings in schools, and in conversation with Jim, as well as our school health nursing team, we certainly did see that reduction in screenings. So I do think that that has also been a contributor for this past school year.
Okay, thank you. Thank you. And one last question that I had was with and this is really more for clarification. We had a presentation from one of the DINE team members, one of our nutritionists, a few months back. And I think we were all sort of devastated by the news that so many cuts were being realized, particularly with our nutrition program. I know it was mentioned, but it looks like it's been confirmed that the Durham County Commissioners has approved funding for our nutrition department through June of 26, June of next year. Okay, awesome.
That is correct. And I'd like to publicly just commend our county commissioners for doing that. I'd also like to commend Chris Salter. There's a significant pot of money that Chris Salter, our environmental health director, manages in the form of public health infrastructure. And, again, we worked it out to where we could contribute funds in addition to the county contributing funds to keep our DINE team working and stable until the end of the fiscal year. We're going to continue, we being myself, the executive team, Micah Gwendon, finance administrator, continue to work with the county budget team to see how we can just kind of work it out to where they could possibly stay a little bit longer. But we have, under the leadership of Rachel Elledge, our nutrition division, we have seen that division to be a little bit more streamlined. There have been a number of individuals who've taken opportunities with other county departments, be it cooperative extension, be it our own environmental health division, be it a number of different places. So that division continues to face its challenges, but they are perhaps some of the brightest people that we have in our agency. They're looking at grant opportunities. They're just looking for ways to build because they do have the ability to do that. So we're just being very creative, Mr. Chair and members of the board, and very forward thinking in our approach. And I just really see good things to come for our Dyne team.
Awesome. Awesome. All right. Any other comments? I'm sorry, I didn't look. I don't see any hands up regarding the director's report, so we'll move on. We have old business. We have quite a few items under old business. We have Board of Health policies 1 through 7 that are need to be reviewed and approved by the board, as well as the Durham County Department of Public Health HD 20, which deals with employee recruitment and retention and professional development. I think with the last one, HD 20, there were a couple of changes. Everything else I think is pretty standard. It's pretty much stayed the same. Hopefully everyone has had an opportunity to review those. Donna was gracious enough to send out that email so we could kind of look at that. I will entertain a motion to approve all of them if there are no questions.
Motion to approve.
I second.
All right, great. It's been moved and properly seconded. If there's no debate, we are ready for the question, Donna.
Okay, Dr. McDougall,
Yes.
Dr. Ray,
Yes.
Mr. Brown, Dr. Glover, Mr. Gregorio,
Yes.
Dr. Jackson,
Yes.
Dr. Miller,
Yes.
Dr. Orto,
Yes.
Dr. Silberman, Commissioner Valentine, Dr.
Yes.
Oh, you're here. Okay. Dr. Verbeest.
Yes.
Very good. Thank you. All right. And under new business, we have 3 budget ratifications. And I'll let Dr. Jenkins present those to the board.
As always, we thank this great board for hanging in there. I'll be very brief. Budget ratification number 1, the board is requested to approve a budget amendment to reallocate $20,373 of previously approved opioid settlement funds from the syringe project strategy to the naloxone project strategy. The Durham County Department of Public Health will utilize the opioid settlement funding to implement evidence-based strategies that prevent overdose and expand access to treatment. Funded activities may include naloxone procurement and distribution of overdose response training, contractual support for harm reduction outreach, referrals, and community education. The second of which, the board is requested to approve budget ordinance amendment to recognize additional funds in the amount of $6,000 from the North Carolina Department of Health and Human Services Division of Public Health, Epidemiology Section, Communicable Disease Branch. These funds will be used to supplement previously recognized funds for fiscal year 26, bringing the total for the grant to $27,517. Using these funds provides additional funding to enable local health departments to implement the electronic test ordering results or eTour system by participating in bidirectional interface project. And the last one is the board is requested to approve budget ordinance amendment to recognize funds in the amount of $3,124 from NCDHHS, Division of Public Health Epidemiology, CD branch. These funds will be used to expand communicable disease surveillance, detection, control, and prevention activities to address COVID-19, public health emergency, and other communicable disease challenges impacted by COVID-19's public health emergency. That concludes the budget amendments.
Thank you. I will entertain a motion to ratify all 3 of these amendments.
Move to ratify.
Second.
All right, it's been moved and properly seconded. If there's no debate, we're ready to vote.
Dr. McDougall,
Yes.
Dr. Ray,
Yes.
Mr. Brown, Dr. Glover, Mr. Gregorio,
Yes.
Dr. Jackson,
Yes.
Dr. Miller,
Yes.
Dr. Orto,
Yes.
Dr. Silberman, Commissioner Valentine,
Yes.
and Dr. Verbeest.
Yes.
Very good. Thank you. Coming to the end of our agenda, I don't see it on here, but oh, here it is. Agenda items for our December meeting, our last meeting of the year. Do we have any suggestions of presentations that this board might want to have at the next meeting?
Is December normally our training meeting?
It's normally a training meeting of Vice Chair Ray. I know you all discussed the possibility of having an in-person meeting, and the staff and I will be more than happy to oblige for that. And the only other thing I have is we probably, between now and that meeting, Mr. Chair, probably need to convene the nominations committee to form the slate so the board can vote for the officers. So that way, when we reconvene in February of 2026, the chair, vice chair, and all the officers will be in place. Those are the only things I could think of as far as procedure.
Thank you. All right. If there are no other suggestions for content for the next meeting, I will entertain, I'll allow for discussion, informal discussion.
I will, as a point of clarification, I also would say, like, the medical director normally gives his annual CD report as well. That's normally a brief yet very informative meeting as well. So thank you to Dr. Jeff Jenks for that reminder.
Okay. So we have a few items. If there's nothing else, I will.
I just have one thing.
Go ahead,
Dr. Ray. And just from a public messaging and communication standpoint, I think that there's a lot of confusion around COVID vaccination status and who should get the vaccine, what community members should do for their kids, how they can access them, that type of thing. I would just a question or would love to. I think that the Department of Health would be a fantastic communicator to help clarify some of this, even for people like myself who should be informed. I'm still confused about this on a regular basis. So just a question around are there plans to do some proactive communication as we've done with other hot topic items to make sure that the public understands what their options are and to dispel some of the confusion that's out there today.
Absolutely, Vice Chair Ray. Thank you for raising that topic, that very important topic. Again, giving credit to the executive team and also to our PIO, Dr. Alicia Smith, as well as our epidemiology team who has been meeting continuously since the pandemic. So that's a solid 5 years. We have been proactive in as much as meeting monthly and tracking daily, weekly. A very wild and frenetic and hard to manage communications from the federal government. Sometimes we find out by tweet, and sometimes we find out by word of mouth. With that being said, whatever we find out and when we find out, I know Dr. Smith puts it out on social media, but I do plan on having a health director chat, if you will, health director communication to the community to really spell out, insert in very slow and methodical and deliberate detail what needs to happen, because there's a lot of confusion. I totally agree. And we also know that vaccines for children, particularly COVID vaccines for children, are normally done at health departments, whereas adults can go to their private providers or, CVS, Walgreens. So with that, we're going to do our absolute best to get our bearings, but admittedly, we have been just as confused, Dr. Ray, but we are in the process of getting that done, and I can see that message from me to the community coming out in short order.
Great. Thank you very much.
Very good. Thank you. Anthony Gregorio, you have the floor.
Yes, thank you. And actually, Dr. Ray, kind of, I guess, joggled my brain. Here's another, I guess, idea for December, kind of similar to my ask for the summer season. What are we, as a community, as the public health board, what are we doing to curtail, a flu and cold symptoms and such for our community? Because of course, with the flu season coming up.
Absolutely. We in that message to the community, Alicia normally has me to really talk about respiratory virus season in total. So we focus on certain parts that are very confusing, which is COVID vaccines, but then we also encourage individuals to really get their flu, RSV, whatever it is. So that will be all in some.
Awesome. Thank you. Anything else? December is filling up. We got a busy meeting. But yeah, if you have if anything comes to mind, please reach out to Dr. Jenkins and his staff, and they can add that to the list of topics to be discussed. All right. If there's no other discussion, I will entertain a motion to adjourn for the day.
Motion to adjourn.
Second.
All right. It's been moved and properly seconded. We are ready to vote.
Dr. McDougall,
Yes.
Dr. Ray,
Yes.
Mr. Brown, Dr. Glover, Mr. Gregorio.
Yes, and happy Halloween.
Thank you. Dr. Jackson,
Yes.
Dr. Miller,
Yes.
Dr. Orto,
Yes.
Dr. Silberman, Commissioner Valentine, Dr. Verbeest.
Yes.
Thank you.
Thank you all. Have a great evening.
Commissioner Valentine did say yes.
Okay.
Thank you all so much.
Thank you.
Awesome.